Hello everyone, I'm here today to present a case series. We have just started this case series on our Facebook group, Reproductive Medicine Masterminds. And this idea was born because I thought that it is very important that we discuss cases with each other and with all the infertility experts and form a group of like-minded people where we can form a platform where we can all discuss our daily problems. And these are the cases which we see in our clinical practice. I'm an IVF specialist from Jindal Hospital, and it gives me great pleasure to tell you that we've had 6,500 deliveries from IVF till today from various techniques of ART. And I have a very important guest today with me, Dr. Shweta Mittal from Gangaram Hospital, who is also a very dedicated IVF specialist and a very keen academician. So I thought my first case, I'll start with her because she's a very keen and a very academic person. And we thought it will be like-minded people. So welcome, Shweta, to this case series.
Thank you very much for very sweet and kind introduction.
Yeah, right. So the first case that I thought about was Hypogonadotrophic Hypogonadism. And I'm going to give you just a very, broad overview of the whole topic before we go on to the case discussion with Dr. Shweta. So I'm going to start my share screening and we'll just give you an overview of the presentation first. So hypogonadotrophic hypogonadism is a very important entity in ovarian factor evaluation, though it forms only 10% of the cases of hypogonadotrophic hypogonadism. And I am happy that it forms only 10% of the cases because it is a little difficult to treat and compared to polycystic ovarian disease, which is commoner. So this is group 1, WHO group 1 of ovulatory dysfunction. And what exactly is the problem here? The problem here lies in the hypothalamic pituitary axis. This is where the problem happens. These are, you can see a bit of a physiology of these HPO axis. These are the GnRH neurons, which are located in the arcuate nucleus of the hypothalamus, and these secrete the GnRH secretions, which through the hypophyseal portal veins network reach the anterior pituitary, and they stimulate the gonadotropes to secrete FSH and LH, which then affects on the ovary to cause folliculogenesis. We all know that. And in hypogonadotrophic hypogonadism, the defect lies here. It is in this hypothalamic pituitary axis. Either it is at the level of the hypothalamus or the pituitary where the problem starts. So it leads to hypothalamic pituitary failure. It leads to prolonged ovarian suppression, leading to very low E2 levels and very low FSH and LH levels. The FSH levels are less than 1 international unit per ml, and LH is also very less. In fact, LH is more sensitive to suppression than even FSH, and E2 levels can be very low, even up to 10 picograms per ml. These are the levels that we usually see in hypogonadotrophic hypogonadism. And treatment we are going to discuss very soon is with for infertility. It is with ovulation induction, which we'll discuss with Dr. Shweta soon. When it comes to the causes of hypogonadotrophic hypogonadism, there are some congenital deficiencies. They could be of multiple pituitary hormones. They could be of isolated pituitary hormones. And we know a syndrome called the Kalman syndrome, which causes very severe form of hypogonadotrophic hypogonadism. And there are certain syndromes like the Prader-Willi syndrome, Lawrence-Moon syndrome, Bardet-Biedl syndrome, and Gaucher's disease also, which are other where in these syndromes also you see hypogonadotropic hypogonadism is very common. There are other acquired disorders also, which are the functional hypothalamic hypogonadism, and in which extreme malnutrition, exercise induced very severely if you exercise, or if then also you can lead to hypothalamic and pituitary failure. Psychogenic hypogonadism, hyperprolactinemia is also a very important reason for acquired hypogonadism, and this has to be treated in a slightly different way in order to get going with the ovulation induction. Cushing syndrome, HIV infection, and even morbid obesity can also lead to functional hypogonadotropic. You switch it off. My screen is gone. Hypogonadotrophic hypogonadism. And even type 2 diabetes is also one of the very rare causes. And medications like chronic glucocorticoid therapy, chronic opioids, psychotropic medications, which result in hyperprolactinemia, because a lot of these psychotropic medicines actually lead to hyperprolactinemia, and that can also cause hypogonadotropic hypogonadism, and anabolic steroids. These are very important acquired causes of this syndrome. A word about Kalman syndrome. This was first described by Kalman in 1944. Thankfully, it is not very common, 1 in 10,000 male births, more common in boys than in girls, and it causes very severe hypogonadotrophic hypogonadism, and it's a rare genetic disorder. And it's associated with anosmia, which is the sense of smell is also deranged in this disorder. And since we said that it is more common in boys, there is a small window of where it can present itself even in very early life. Otherwise, it presents only at puberty. But in boys at 0 to 3 months of age, if they have undescended testes and cryptorchidism and small penis, this means they could be having Kalman's disorder. So if you are alert, even as a neonate, this disorder can be diagnosed by doing the genetic testing early in life. Sometimes it may be associated with cleft lip, cleft palate, hearing loss, and even renal agenesis can be associated. These boys and girls are born with secondary sexual characteristics are delayed. So in girls, the menarche is delayed, and in boys, they have all the problems of hypogonadism. It is diagnosed by genetic testing and treated by hormones. And if we were to see the genetics, if we to see what causes it, in 68% of the cases, we don't know what causes it. And there are a lot of genetic mutations, like you can see here, there are so many types of genetic mutations. So all this genetic mutation concerning the GnRH receptor genes, if there are any mutations in this, it can lead to Kalman's disorder. So then you have to involve a geneticist in order to diagnose it, because they do the genetic testing to know whether the CAL1 gene, as I was talking to my geneticist, and she said that this is what we do and to diagnosis. There are a lot of rare syndromes which can also be associated with hypogonadotrophic hypogonadism. As I said, Prader-Willi syndrome is one of them, which is caused by microdeletions of mutations on paternal chromosome 15. So what I wanted to emphasize is that these boys can be born with or at puberty they can have obesity, cryptorchidism, short stature, mental retardation. And as an infant, which is in boys, you get a period from 1 to 3 months where you can diagnose it if the boys have a small penis or have undescended testes. That is when you can diagnose it earlier in life. There's another very important differential diagnosis to it, that it could be CDGP. CDGP is constitutional delay of growth and puberty, and this is very commonly seen. A patient who comes to us and she doesn't have a period by the age of 16 years, or if she doesn't have thilarchy, which is the breast development, by the age of 14 years, you could suspect CDGP. That is constitutional delay of growth and puberty. And to distinguish it from congenital hypogonadotrophic hypogonadism, you have to do all the fertility tests, the AMH, the inhibin B, and the other fertility tests like FSH, LH, prolactin, and TSH. And you have to do a gonadotropin releasing hormone stimulation test, the GAST test. And if you get a normal response to your GnRH stimulation test, then the patient could be suffering from actually constitutional delay of growth and puberty. And it is very important that in these cases, you have to get their bone age done to know whether the age they are telling you is the right age or not, because they might tell you that they are 16, but actually they might have misinterpreted it. They might not be 16 years. Whereas in hypogonadotrophic hypogonadism, you will get very low AMH level, inhibin levels will also be very low, and you will get a deficient response with GnRH stimulation test. This is how you distinguish between the two disorders. Another differential diagnosis, because when a woman who comes to us with delayed periods, then you think of Turner syndrome also. But Turner syndrome will have a characteristic features. She will look Turner's. If you look carefully, there are certain features of Turner syndrome which will tell you whether it is Turner's or not, like a small mandible, high arch palate, low set ears, shield-shaped chest, and even lymphedema on hands and feet. And she will have, short stature, webbed neck. And when you do an ultrasound, of course, you will find that the ovaries are very small. They are almost indistinct, which you find in hypogonadotrophic hypogonadism. But what will clinch the diagnosis is your karyotyping. When you do a karyotyping for these girls, you will find XO. So that is how you distinguish from hypogonadotrophic hypogonadism, which usually, don't disturb it right now, please. Don't do that. I don't like it in the middle of it. I'm in the middle of the lecture. Just let it go. So by looking at her faces and her whole, structure, you can make out that as Turner syndrome. I've included a typical picture of a girl with Turner syndrome. Look at her webbed neck, short stature. The very mandible is also very different looking. So this is how you will distinguish it from congenital hypogonadism. Then there is a Tanner score to know the breast, staging of breast is done by the Tanner score. And I would just like to repeat that stage 4 and 5 constitute a good mature breast development, and anything less than 3, 2, and 1, these are all very undeveloped breast development, and pubic hair and even in boys, the genitalia will also be affected in hypogonadotrophic hypogonadism. Since I'm not talking about boys, we will just concentrate in women. So you have to do their secondary sexual character. You have to know this. You have to do the scoring for that, so that you know at what stage she is. Because if she has underdeveloped secondary sexual characters, she would require some hormonal treatment and treatment at the earliest, so that she can, have her sexual development. The effect of estrogens, as we all know, it affects our whole body. And estrogen is a very protective hormone for women. And it is this hormone which these hypogonadotrophic hypogonadism patients lack. So it not only affects her ovaries and her uterus and prepares the uterus for menstruation every month, it also has a role in breast growth. And we all know even in lactation, as well as in all our infertility problems, estrogen is very important, as well as in brain, body temperature adjustment, memory, libido adjustment. It also has a protective effect on heart by decreasing the cholesterol levels, on liver by decreasing the cholesterol level and regulating its production. It strengthens the bone and it improves the bone density, and it has an anti-aging effect on the skin. So all these effects on estrogens, this is what we have to, provide to these women who are actually deficient in estrogens. And that is why the earlier we diagnose it, the more help we can do for these women. When it comes to fertility, you'd see they have very small ovaries. Sometimes it's very even difficult to see on transabdominal. This is a transvaginal scan, which shows very scanty follicles. You can hardly see any follicles, and these two are also looking like very inactive follicles. So small ovaries with very inactive follicles. So this is the picture that you get on transvaginal. And to improve their bone health, to provide their bone health strength, you have to get a Dexa scan done. And a Dexa scan will tell you whether she falls into a normal range, osteopenia, or osteoporosis, and accordingly you have to treat these women. And my last slide is you do a T-score, and then you decide whether she needs, whether her bone loss is normal, her bone density is normal, is it low bone mass, or is there the presence of osteoporosis, and you have to treat them accordingly. The treatment we are just going to discuss when we do the case discussion, but I thought I will just complete it by saying this given by giving them estrogens and progestogens. Estrogens in the form of either pills, estradiol valerate, estradiol hemihydrate, or transdermal gel like estrogel can also be given. Vaginal creams are not usually preferred, but is one of the options available to us. Progestogens in the form of dydrogesterone, micronized progesterone, or even medroxyprogesterone acetate can be used. And if we are to treat them for their infertility, 3 to 6 months of estrogen priming with withdrawal bleeding, followed by either with gonadotropin releasing hormone pump or gonadotropin releasing hormone subcutaneously, which is usually not done or can be done in special settings, and ovulation induction with FSH and LH, either HMG or even recombinant, will give you more efficacy. And if nothing is successful, then these patients can be taken up for ART. And it is not necessary that you have to provide them donor egg. They can be stimulated. Their eggs can be harvested, and they can have their own, they can have pregnancy from their own eggs. With this background in mind, I'm going to go on to the case presentation, and then we are going to discuss the case with Dr. Shweta at large. This 28-year-old lady with primary infertility, married for 1.5 years, came to me with secondary amenorrhea since 6 months. She said she gave a clear history that her periods came at the age of 16 years after taking hormones, which means she had primary amenorrhea, and she was told by her general practitioner, please don't disturb her. She was told by her general practitioner that she would get better after marriage, which I have seen in my practice is a very common thing. कि पॉलिसिस्टिक का कोई इलाज की जरूरत नहीं है, जब शादी हो जाएगी अपने आप ठीक हो जाएगा. ये मेडिसिन से आया है, दवाइयों से आया है, ये बाद में जब शादी हो जाएगी ये भी ठीक हो जाओगी तुम. So this is a very big, lack of awareness in our society, that they think that after marriage the hormonal disturbance, whatever she has, will become okay with a sexual life, but that is not so. On general examination, her breast development showed the Tanner score 3. Her axillary hair and pubic hair were present. Almost, again, score was 3. On examination, she had a nulliparous os. On pelvic examination, it was absolutely normal, except that the adnexa was, the uterus was small in size. On ultrasound, it measures 56 into 26 into 32. Endometrium was thin, and because she was amenorrheic for 6 months, 5 millimeter, and bilateral ovaries 2 into 2 into 1 with very scanty follicles. Hardly you could see her ovaries. Her FSH was 0.2 milli-international units, LH 0.6, prolactin was 10.8, TSH was 3.2. Her E2 was just 11 picograms per ml. Her AMH surprisingly was 1.3 nanograms per ml. I got a karyotyping done to rule out any other problem. As we said, she could be, the first thing that comes to mind is she could be Turner's. but she came out to be 46XX. So Turner's was almost ruled out. So I'll stop the share screen and we'll go on to the case discussion with Dr. Shweta. Yeah, Shweta. So my first question to you is, okay, it's over. That what do you think? What is the cause of hypogonadotrophic hypogonadism in this patient? What do you think? What went wrong?
Yeah, I'm sorry. I think I went off hook for some time.
So, what do you think is the cause of hypogonadotrophic hypogonadism in this case, Shweta? She
So,
has
if
very
we
low
look at,
hormones.
yeah. So if you look at the history, this girl was a
Yeah.
case of primary amenorrhea, and the first time she got her menstrual cycle was with the help of a withdrawal bleed. So we know that the cause was very congenital in her case; it's not acquired, and it was possibly right from birth. So this is
Yeah.
the diagnosis.
Absolutely.
So I think when this girl would have presented to an OPD, if we remove the investigation parts, so she would be like a primary amenorrhea where we would have an opportunity to examine her clinically, and then from there we will be coming to
No,
some
but she
kind
was
of
not primary amenorrhea,
a.
Shweta, because she had her period because she was given some withdrawal bleeding
That's what I'm
at the
saying.
time.
But if
Yeah.
you go back to her age, like at 16
Yeah.
or 18 years when she
Absolutely.
must have reached, she was a case of primary amenorrhea. So this cause is
Right.
very congenital and it's from the beginning. So this is what I'm trying to say, that it's not acquired.
Right. Right. Absolutely. Right. So how do
So
you clinch the diagnosis? By
yes.
doing the fertility profile, and
Yeah,
how do you go about working up
so
these
let's
patients?
divide. Let's divide that this case comes to the OPD for the first time,
Yeah,
primary amenorrhea, and does not have any investigations. So in the OPD, I think it is very important to know whether she has a vaginal outlet or not. Now, in case
very
she's a
true.
young unmarried girl, maybe you'll not be able to find that out in your OPD setup. Number two, if you have an ultrasound in your OPD setup, maybe you will be able to do that right there and there itself.
Right,
And you will
absolutely,
be seeing some
absolutely.
uterus and you would be seeing maybe small streak ovaries. So if the vaginal outlet is there and she has a uterus and streak ovaries, then we know that we are not dealing with a Mullerian agenesis. So that cause of primary
Absolutely,
amenorrhea is ruled out. So when there is
absolutely.
primary amenorrhea with the vaginal outlet, then there are two diagnoses. Either she will fall into a WHO type 1, which is hypogonadotropic
Okay.
hypogonadic, which is
Yeah,
more central in cause, or she will be
right.
hypergonadotropic, which is primary ovarian failure. And the only one test, if suppose I am asked one test, what you would do, I would say an FSH. So an FSH would be one most important leading test in these two girls. Of course, we will be adding an LH. So if you are dealing with hypogonadotropic hypogonadic, very typically in this girl, both the levels were less than 1. So they cannot be in a case of primary ovarian failure. They will be in a case which is central.
Like in Turner syndrome.
So in
Yeah,
Turner, suppose this same picture would have been Turner's where the primary cause was ovarian failure, the FSH would have been very high. So typically we
right.
get an FSH
Absolutely.
like 40, 60, 100, even 150 I have seen. So this is a very, very major difference. Only
Yeah,
thing is word of caution that like a 28-year-old girl comes, just make sure that she's not on prolonged OC pills before you get these hormones done, because they can be very misleading. Very prolonged OC pills can also suppress FSH and LH. So
LH.
please see to it that you're doing it at the right time.
Yeah, that is very true. And so you could elicit the history that she's not on any oral contraceptive pill.
Yes.
And do you come across cases of functional hypogonadotrophic hypogonadism as well in your practice? Have you? And what is usually the main cause?
So, last year one girl had come from Bihar to me, and her typically her parents would say that she has a little less concentration in studies. And then I started thinking that is it some kind of a fragile X syndrome she's having. But then when I really delved into it, and I realized that this girl was
Yeah,
almost a case of anorexia, and her BMI was very low, so very strenuous life with a lot of exercise, or anorexia nervosa is one physiological cause of hypogonadotropic hypogonadism, and very severe hyperprolactinemia. So these are the two things which we need to keep. But I think in my clinical practice, I see more of congenital and more of unexplained hypogonadotropic hypogonadism, if I want to look at all the
And
causes.
in congenital hypogonadotrophic, what is the main cause for congenital? What in your practice? What do
Yeah,
you
so
see
you know,
normally?
if we really get into academic
Yeah,
diagnosis, which we are not doing it, most of the
yeah,
times our diagnosis curtails at clinical diagnosis of hypogonadotropic hypogonadism. Let
absolutely.
me be very frank that I'm not getting the Cal1 gene or FGR, though it is available in my hospital, but maybe it is just to diagnose whether they are hypoosmic or they are normoosmic hypogonadotropic hypogonadism, and if we want to know if there is any X linked, that is why males are more commonly affected, because there is also an X link, but it can be autosomal recessive, it can be autosomal dominant. So if you,
Dominant,
it's for
absolutely.
more of an academic purpose, but yeah, if clinically I know that she's hypo, then my treatment per se will not change for her, even if I delve into, yes, for prognosticating and for transmission in the family is something which I can do if I
Yeah,
can find it out.
right. So if you should elicit a history of positive family history, if the patient gives a family history,
Yes.
then definitely you should be more alert about it, and you can go for genetic testing for these patients to see whether they really in which category of hypogonadotrophic hypogonadism they fall into. And how do you distinguish between, let's discuss this constitutional delay, because that is also quite
Yes.
common, of puberty and development, which I just discussed in my slideshow
So,
also. So,
so if constitutional delay we are looking at, so we are looking at two cases with FSH and LH low, and we don't know that when this pivotal spurt will come. Then,
yeah,
one hormone which we normally don't do is inhibin B, which can be, made use of, because in a constitutional delay, the inhibin B will be higher. The second is a
very true.
GnRH agonist stimulation test. So if we give
Yes,
intravenous 1 milligram of leuprolide and we do a
yeah,
baseline FSH LH, and then we do it after 30 minutes, 60 minutes, and even people have done it after 24 hours, and you see a rise of FSH LH, then you know that this is a case of constitutional delay and not
yeah.
a true case of hypogonadotropic hypogonadism.
Yeah, because a patient of hypogonadotrophic hypogonadism will have a blunted LH and an FSH response even to the Lupride injection, whereas a patient with constitutional delay will have a very good response and will show a rise in both FSH and LH. And another test which I would just like to mention here is that you can give FSH to these patients, and if they have a good increase in the inhibin level, this means they have a very active hypothalamic pituitary axis. Whereas if it is a blunted response on giving FSH and the inhibin levels are low, this means you are dealing with hypogonadotrophic hypogonadism. So that was very well elicited, Dr. Shweta. And now as I said in my history, that she has been married for 1.5 years and she is very keen to conceive. So, what do you think? You will first like to give her, estrogen, progestogens for some time, or you will just like to take her up? How would you go about treating these very difficult cases?
So, number one, a positive counseling, I think, is very important for these girls. These girls are
Yeah,
born with a central defect and it can be tackled. 90% of the times you will be able to achieve an ovulation for them. So the first thing to start is, because she's not been on any hormones for 6 months. So I would start priming, because it is very important that even uterus needs to be primed before it receives the, fertilized egg. So what is important is I would give her an unopposed estrogen. Her endometrium was 5. Sometimes you will see women who come with endometrium of 2 and 3. So I give an unopposed estrogen, say for about 4 weeks. I call them for an endometrial thickness. I'm looking at endometrium crossing 6. Suppose it has
yeah,
not crossed 6. I would keep giving the estrogen, and I normally give it up to 3 months unopposed. So suppose if she's, most of the times my experience is that in these 3 months she will form an endometrium which is more than 6, and that is the time where I will add a progestogen for about 5 to 7 days and bring a withdrawal. So my aim is about 3 months of priming, and once they are primed, then the answer for fertility to these girls is only and only one molecule, which is an FSH and an LH molecule. Now, this could be given with the help of a simple HMG injectables, Or the second step could be a recombinant FSH and LH, but
Extra
can be a
knowledge.
very expensive, yes, can be a very expensive venture. So if I have to start, I would start with a 75 unit of FSH. I will give it for about 10-12 days. I will not call her before that. And I like to monitor with estradiol level. And when I see a follicle which is 10 millimeter and above, and the E2 crosses 100, which may not happen in this case in 10 to 12 days,
Yeah,
I will
absolutely.
call her again after 7 days, and now I will increase her dose of FSH. Also, I have this flexibility that now we have the multiple dose HMG vial, so you can actually increase it by 50%. Also, you need not increase it by 100%.
Yeah, yeah.
The aim is, yeah. So the longest I have given in my clinical practice is about 40 days. I've given it for 40 days. Do not withdraw drugs. Do not withdraw before 30-35 days. And in literature, about 100 days of gonadotropin is, or 120, if I'm not wrong, has been reported where it brought a folliculogenesis. I have not clinically given, but most of my
But on,
patients,
on an average, what is the
20
duration
days
of their
on an
stimulation?
average,
Absolutely.
minimum about 20 days to up to
Yeah,
35 to 40 days is something which I have given.
yeah,
Most of my patients respond. But do
right.
not give alternate day gonadotropin. Do not withdraw within 14 days.
Absolutely.
Check the efficacy of your molecule, what you are using. Check the cold chain of your molecule. That's very, very important.
Very true, very true. And that's very true that these patients are also very prone to hyperstimulation. I have seen these hypogonadotropic hypogonadism not showing a response till 15, 20 days, and
Yeah.
suddenly they will come up with such a prolific response, just like a polycystic ovarian disease.
Yes.
And have you had an opportunity of using GnRH agonist pump or subcutaneous
Uh,
injections to induce
no, so
ovulation in these
my
patients?
generation, I don't think has seen a pump. I mean, it's not in
Yeah,
India. So all those, I think one generation before me must have seen pumps, but in other
yeah.
countries. So
Yeah, that
I
is
have
true.
not seen.
That
I
is
have
very
not
true.
seen.
I would agree, but I was going through the review of literature,
Yeah.
and it is said that GnRH agonist actually by pump or by subcutaneous doses given daily actually is safer for these patients compared to FSH and
Yes,
LH, which we all,
definitely
yeah,
more
more
physiological.
physiological,
Yeah.
more physiological. And if she was not wanting a pregnancy, then how would you give her estrogen, progesterone hormone over a long period of time?
Yeah.
Because this is like a very difficult situation to handle in the future as well. So, what is
So
your take on that? How long do you give
yeah.
estrogens, and in what form do you give estrogen and progestogens to these patients?
So, on one hand, we are looking at bone health. On the other hand, we are looking at reducing the chance of something like CA breast because of unopposed estrogen. So,
Absolutely.
what we can do is that we can put them on a combination of estrogen with a very low dose estrogen with progesterone, because we know that they will be taking it for more than 2 decades, maybe 2 decades. Because
Yeah.
see, this girl started, if this particular girl from 16 years till 28, she will have a fertility in 1 or 2 years, and then later on she will be again back to the same situation, and we will be putting her on HRT, and maybe she will need it because the HRT is recommended till the time of natural menopause. So the only thing
Yeah.
what we need to take care is that we look at her bone health, which you very nicely elaborated with the help of Dexa scans. We don't let her go into osteoporosis. We build up her estrogen, and we build up with calcium and vitamin D. On the other hand, to reduce the incidence of CA breast or any estrogen dependent tumor, you keep adding a progesterone, and you give a low dose estrogen along with your progesterone with estrogen to prevent this risk. So this is what I would do. And yes, in between, I also like to do a liver function test, which I do for these
Yeah.
patients.
Yeah, that is very true. And as you said earlier, that it is not important that they get a withdrawal every month. They can get it after 3 months, 4 cycles of withdrawal, 4 times in a year. If they get period, that is good enough. What is your take on that? That it is not necessary that they should get their
Okay, so
periods every month.
I normally was suggesting 8. I don't know what the literature, I mean, if you've done that search, because I
Yeah.
normally target at around 8 cycles in a year.
Huh.
So
No,
basically,
it's
the
as long
estrogen,
as it's 4 cycles. If they get their periods every 3 months, then also, and it is, you can check out the endometrial lining for any endometrial hyperplasia. So it is good enough that even if they don't get the periods every month, that
So
is
I
fine.
like to add a small dose of medroxyprogesterone to these
Yeah.
patients,
Huh.
and that is it.
And what about oral contraceptive pills? You think these patients can be put on oral contraceptive pills of something like Novolon, or which has less
So
of androgenic side effects? That can they be put on these for a long
we,
period of time?
we can be put on OC pills also, but when patients are trying for fertility, because
No,
OC
not for
pills give
fertility. We are talking
ectopic,
about non-fertility.
yeah,
Now we're
atrophic
talking about,
endometrium, then yeah, the literature does say that those sequential estrogen and progesterone will be better for them, but they can be put on a low dose OC pill, and I think we all put them off and on
yeah,
them.
absolutely. That is what I was trying to bring this point forward, that these patients actually do very well on OC pills as well if they
Yeah.
are not keen to conceive. And that also is quite safe, because OC pills on a longer period of time can be safely given. You can give them like desogestrel containing progestogens like Novolon or Juliana, and all these can be given to these patients. And what are we have already discussed the long term consequences, and you very well said that LFT should be done in these patients, because if they are on prolonged estrogen therapy, that should really be looked after. The liver should be looked after well. And any link with obesity? Have you seen hypogonadotrophic hypogonadism with obesity, and what category do they fit into, and how do you go about treating them also with obesity? Any relationship?
So yes, hypo patients can have obesity because simultaneously they can have leptin deficiency. So we know that leptin is normally a satiety hormone, and it curbs our hunger. So those patients who are leptin deficient can have a lot of hunger and will not have satiety, and that is what happens with hypo patients, and they can have obesity. So and then you said that gross obesity in itself can cause secondary
Acquired cause. Yeah.
as an acquired cause, and for a
Yeah.
congenital one it is mostly associated with leptin deficiency. So yes, you can find that.
Yeah, like the special syndromes that I mentioned, the Lawrence Moon Middle syndrome,
The
these can be
Prader,
associated
yeah,
with,
yes,
yeah,
yes,
Prader-Willi syndrome. These can be associated with obesity, and especially in boys, you can see that because it's more commoner in boys, four is to
yes.
one ratio. So in these patients, because of the high obesity levels, there is conversion of testosterone to estrogen levels. So they are hyperestrogenic, their T ratio gets disturbed, and there are problems which follow because of that. And obesity is also one of the association with that. And what about the functional hypogonadotrophic hypogonadism? What we discussed, that athletic girls who are exercising strenuously, even they land up with amenorrhea, and actually it is
Yes.
hypogonadotrophic hypogonadism. So, can hypogonadotrophic hypogonadism be reversed? If I may put this question across to you.
So all the treatable causes of secondary hypogonadotropic hypogonadism can be reversed. Like if suppose hyperprolactinemia is the cause, if antipsychotic drugs is the cause, or if excessive exercise induced or anorexia, if they are corrected, yes, hypogonadotropic hypogonadism can be corrected. But congenital, no. If you are
No,
looking
yeah,
at Sheehan syndrome, apoplexy, then no. If you're looking at something like hematochromosis, which is causing it, no. So the correctable causes, yes, of secondary hypogonadism possibly can be corrected, but
yeah.
congenital cannot be.
Yeah, very true. I think you have really said it very well. And a word about hyperprolactinemic hypogonadism. How do you go about treating them? First, you treat their hyperprolactinemia, and then you go on to it.
Yes.
How do you go about it?
Yes, so very severe hyperprolactinemia. Number one, I will also look at the thyroid dysfunction. If there is no hypothyroidism causing hyperprolactinemia, so we go step by step. We look at the causes of, or if we can find a possible cause of hyperprolactinemia, we
Like a
treat
pituitary
that.
adenoma, like a
Yes.
pituitary adenoma,
So if there is a
microadenoma.
prolactinoma, if there is a prolactinoma, definitely we will treat it, because possibly by shrinking of the prolactinoma, we are looking at better impulse and better pulsatility and restoration of your FSH and LH. But
Huh.
some patients will also need, ovarian stimulation along with treating these causes, because maybe it will not reverse so soon. So we need to know that also.
Yeah, very true. So you need to treat their hyperprolactinemia before you embark on ovulation induction, but because merely treating hyperprolactinemia can also reverse their hypogonadism. That is
Yes.
one thing I wanted to bring out. So you think it is very important to diagnose them earlier, at the earliest. And like I said, in boys there is a small window from 1 month, from 0 year to 3 months, when undescended testes and cryptorchidism seen in boys can actually diagnose it as early as by 3 months of age, which is not so in girls. So what is
So
your
I
take on
think
that?
in both, when it comes to hypogonadism, hypogonadotropic hypogonadism, if you're looking at boys, we are looking
Yeah.
at better penile growth and we are looking at better testicular growth, because undescended testes, if left untreated after 1 year, can cause
Yeah.
an irreversible damage to spermatogenesis. If you're looking at girls, we are looking at better secondary sexual characters and better estrogen priming. This is the aim, better uterine growth and better priming of the ovary. And when we are looking at fertility, we are looking at better response. So before puberty, during her growth phase, we need better growth, better breast development, because they are hypoestrogenic. So they need that better height, better secondary sexual character. So yes, earlier it is diagnosed, the better it is to approach this problem both in girls and boys.
Yeah, I think you have said it so well, and you have really summed it up so well, that it is very important to treat it at the earliest, because you can ensure their reproductive health, their sexual health, their secondary sexual character development, and even the psychological thing which goes with it. I've not had my periods on time. An adolescent girl who doesn't have periods on time actually is under a lot of stress, because all her peer girls have had it and she's not had it. So I think we need to address this also when we're treating this
Yes.
very difficult condition. So this was the end of the show, and thank you, Shweta, for answering the questions so well and making it so nice for us. I wish
Thank you
there
for
is,
your
can we have the
time.
questions? Questions. I don't know if there are any questions in the question bank, because in the chat box, because I can't see any chat box here. No, there, no, there are none. So I think we'll let it be. Shweta, you've really clarified so many issues,
Thank you
and
so
thank
much.
you for joining us. Thank you so much for this very
Thank you,
nice
Dr.
input that
Anku.
you
This
gave.
is a very good initiative, and I hope that in some time a lovely bank would be made of all the cases, and people can always come back and refer to them, whatever are discussed and archived. So, thank you, and
Thank
all
you.
the
Thank you so
best.
much.
Yeah.
Yeah. Okay. Bye. Bye, Shweta.